Welcome to part 2 of our Oasis Review and QA training series. In part 2, we'll take a deeper dive into diagnosis coding and its impact on PDGM, orders for discipline and treatment, goals, medication profile, and general Oasis QA best practices with practical examples. Let's dive in. PDGM and reimbursement, primary diagnosis coding accuracy. Primary diagnosis in home health refers to the condition that is the chief reason for skilled home health care. Under PDGM, patient-driven groupings model, CMS classifies patients into a clinical group based on the primary diagnosis code. If the primary diagnosis is vague, non-billable, or doesn't support skilled need, the case may default to what is referred to as a questionable encounter that can result in a rejected claim. Best practices for primary diagnosis accuracy. 1. Must reflect the skilled need. Example, I69.354. Hemiplegia and hemiparesis following cerebral infarction affecting left non-dominant side for a patient discharged home from hospital following a recent stroke would support the skilled need for restorative therapy of physical therapy, occupational therapy, and speech therapy. 2. Avoid questionable encounters. Questionable encounter codes often involve unspecified, unexplained symptoms or unusual external causes, prompting queries for underlying conditions instead of simply coding the symptom or event. The goal with these codes is to identify the root cause for accurate diagnosis and treatment. CMS has a list of non-acceptable primary codes that don't group into PDGM clinical categories. These ICD-10 codes do not calculate a grouper payment in PDGM when used as a primary diagnosis, hence $0 reimbursement until corrected. They may, however, be used as secondary diagnoses. 3. Must be consistent with physician's listed focus of care diagnosis on the face-to-face documentation. Under PDGM, if the diagnosis that drives grouping is not supported by a face-to-face, CMS can rule the episode non-billable. CMS requires that a physician, or allowed nurse practitioner or PA, documents a face-to-face encounter with the patient within 90 days prior to start of care, or 30 days after start of care. The listed diagnosis, reason for home health in the face-to-face, must match the primary diagnosis coded on the Oasis and plan of care. It is best to go with the written-out form of the diagnosis rather than the listed diagnosis code for accuracy. When in doubt, clarify with MD's office. Example, MD documents acute on chronic systolic CHF but code listed as I50.9 heart failure unspecified. It is okay for the coder clinician to code I50.23 based on the narrative. Because coders cannot assign or sequence codes based solely on physician preference or wording, there are times when the sequencing rules override MD's listed primary diagnosis. In these scenarios, clinician, QA, and coder must ensure that the coded primary diagnosis aligns with the face-to-face but also follows coding guidelines. Example, MD documentation reads, acute on chronic diastolic heart failure due to hypertension with moderate to severe CKD. These codes fully capture the patient's conditions and the causal relationship between hypertension and the heart and kidney disease. Even though acute on chronic diastolic heart failure is mentioned first, it would not be the primary listed diagnosis. The correct coding and sequencing will be I13.0, hypertensive heart and chronic kidney disease with heart failure and with stage 1 to 4 CKD or unspecified, I50.33, acute on chronic diastolic congestive heart failure, followed by N18.32, chronic kidney disease stage 3B. Primary diagnosis and impact on PDGM clinical grouping. Always remember that the chosen primary diagnosis code determines the clinical group. If the primary diagnosis code is on the acceptable list, it is assigned to one of the 12 clinical groups. Make sure that your primary diagnosis code is at the highest level of specificity. Always code to the highest level of detail available in the record. Capture type, acuity, stage, laterality, and combination codes. Comorbidities and impact on PDGM. CMS recognizes that patients with multiple chronic conditions are more resource-intensive, more nursing visits, more complications, higher risk of hospitalization. PDGM has a comorbidity adjustment built into payment as follows. No adjustment, patient has no qualifying comorbidities. Low comorbidity adjustment, patient has one comorbidity from CMS's approved list that is associated with increased care needs. High comorbidity adjustment, patient has two or more comorbidities from different comorbidity groups, which interact to create even greater resource needs. Always cross-check with face-to-face H&P and progress notes to ensure that all diagnoses are coded into the highest specificity. Watch for missed combination codes. Example, patient A, CHF only equals low comorbidity adjustment, which equals modest increase in payment. Patient B, CHF plus diabetes with neuropathy equals high comorbidity adjustment, which equals larger increase in payment. When auditing primary diagnosis, ask the following questions. Does the code support the skilled need described in the plan of care? Is the code billable under PDGM, not a questionable encounter code? Does it match physician face-to-face documentation? Does it place patient in correct PDGM clinical grouping? Are secondary diagnoses used to capture comorbidities for comorbidity adjustment? Is the code as specific as possible? Orders for discipline and treatment. These are the orders that drive the plan of care and that direct what skilled services will be provided, at what frequency, and for how long. Apply to skilled nursing, physical therapy, occupational therapy, speech therapy, MSW, and home health aid. Must be specific, match the patient's clinical needs, diagnoses, and Oasis documentation, and must be signed and dated by certifying physician. Must specify frequency and duration, that is, how often and for how long. Example, skilled nursing 2 week 3, 1 week 6, physical therapy 3 week 2, 2 week 4. PRN orders must be specific. For example, 3 PRN visits, soiling, or dislodgement of wound dressing. Treatment orders include the specific skilled interventions. For example, wound care, IV therapy, diabetic teaching, strengthening exercises. Orders must be reviewed and updated at least every 60 days upon recertification or when patient's condition changes. Goals. A goal is what the patient is expected to achieve as a result of skilled care. Goals must be specific, measurable, achievable, relevant, and time-bound. Examples, ambulation. Patient will increase walking distance from 50 feet to 150 feet with walker within 4 weeks. Medication management. Patient will independently set up pill box and take all medications as prescribed for 7 consecutive days within 3 weeks. Vital signs and symptom alignment. Next, let's make sure vital signs line up with what's charted in Oasis. Example, patient with heart failure, heart rate 128, respiration rate 28, O2 sat 90%, shortness of breath checked under respiratory assessment, but narrative says patient asymptomatic, clearly inconsistent, needs revision. Medication profile. When auditing, QA should ensure that medication profile has name, dosage, route, frequency, indication, and start date and match the prescribed medication in the home. All medications listed match the physician's most recent orders. There are no duplicate medications, for example, same med listed under different names. PRN meds include indication. High-risk meds such as anticoagulants, insulin, digoxin, etc. are documented with teaching and monitoring interventions. Ensure no contradictions, for example, patient allergic to penicillin but profile lists amoxicillin. Medications are updated at every visit if changes occur, not just on start of care. Abbreviations that can cause confusion are avoided. All discrepancies are clarified with MD and pharmacy. Oasis QA best practices include side-by-side comparison of Oasis, visit notes, therapy evaluations, plan of care, physician orders, and face-to-face documentations. Ensuring responses reflect the correct time frame, not just day of visit for items that require a 14-day or 60-day look back. Using Oasis scrubbers within software used, but never relying solely on the automated feedback. Keeping up to date with CMS guidelines and keeping the latest CMS Oasis guidance manual accessible. Staying up to date with ICD-10 coding updates. Providing specific educational feedback, not just corrections, to clinicians on recurring issues. Maintaining a log of recurring Oasis errors noted. and using the information for targeted in-service training. Completing QA on time to meet required submission deadlines to avoid export rejections and deficiency flags by setting QA timelines using trackers for pending Oasis. Tracking QA pass rates for each clinician to support performance reviews and ongoing improvement. Oasis Narrative QA. QA should ensure narrative includes patient ID and living situation. Example: Mr. James Smith is a 78-year-old male admitted to home health following recent hospitalization for CHF exacerbation. He resides with his spouse in a single-story home. His wife provides some assistance but is limited by her own health issues. Diagnosis impact on function. Example: primary diagnosis of CHF results in dyspnea with exertion and fatigue after walking 50 feet. Hypertension and CKD, stage 3 complicate management and increase hospitalization risk. Functional status summary. Example: patient requires assistance with bathing and dressing, ambulates short distances with a walker, and experiences dizziness with position changes. Medication management is impaired due to memory lapses, requiring caregiver support. Skilled needs, justification. Example: skilled nursing required for cardiopulmonary assessment, education on daily weights, and medication teaching for new diuretic medication, Lasix. Physical therapy needed for gait training, strengthening, and fall prevention. Risk factors, hospitalization, fall safety. Example: patient is at high risk for hospitalization due to unstable CHF, polypharmacy, and history of frequent falls. Safety risks identified in the home include cluttered walkways and absence of grab bars. Patient goals. Example: patient states his goal is to be able to walk to the bathroom without getting short of breath, to manage my medications without missing doses, and to feel clean and independent with bathing. Measurable time-based goals. Example: patient will verbalize understanding of prescribed CHF medication Lasix, including purpose, schedule, and 2 potential side effects within 14 days of teaching. Medication reconciliation and teaching. Example: medication reconciliation performed and discrepancies noted. Duplicate therapy identified. Patient taking both simvastatin 20 mg at bedtime, old prescription, and atorvastatin 40 mg daily, new prescription. MD notified immediately. Clarification received that only atorvastatin should be continued. Patient instructed on potential side effects of statin therapy: muscle pain, weakness, GI upset. Instructed patient and caregiver on how to monitor the effectiveness of the drug therapy, how to recognize potential side effects, drug reactions, duplicate drug therapy, non-compliance, and how and when to report problems to skilled nurse and MD. Caregiver instructed to keep a single updated medication list and to properly dispose of discontinued simvastatin. Medication profile updated, reviewed with patient and caregiver, and revised copy given to patient. Education needs. Example: patient and caregiver require education on CHF management, daily weight monitoring, low sodium diet, and safe medication administration using a pill organizer. Discharge planning. Example: discharge planning initiated and discussed, anticipate transition to independence in ADLs with spouse support. Patient and caregiver orientation on admission. Patient and caregiver instructed on home health agency business hours of operation, after hours, weekends, and holidays on call procedure. Instructed on role of home health agency, Oasis data collection tool, role of home health nurse, agency expectations, patient's rights and responsibilities, financial responsibilities, client conduct. Patient and caregiver instructed on complaint and grievance procedure, abuse, neglect, and exploitation agency policy, RN supervision, charges, HIPAA, and advanced directives. Pertinent toll-free numbers to Department of Aging and Disability and Medicare shared with patient. Instructed on emergency disaster preparedness and importance of registering with 211 in case of evacuation needs. Plan of care discussed with patient and caregiver and both agree with plan of care. Plan of care discussed with MD and verbal approval given. Remember, consistency is everything in Oasis. Accurate Oasis reviews protect compliance, ensure proper payment, and most importantly, support safe and effective care planning for your patients. Thanks so much for watching. If you found this video helpful, give it a thumbs up. It really helps others find it too. Don't forget to subscribe so you don't miss out on more tips and resources. Looking for easy-to-use digital tools for managing home health? Check out my Etsy shop. Link is in the description. If you have questions, ideas, or want to share your experience, leave a comment. I'd love to hear from you, and feel free to share this with anyone who might find it useful. See you in the next video.